Welcome to the Human Factors and Ergonomics Hub, a series of educational podcasts that showcase the connection between human capabilities and good work design, brought to you by the Human Factors and Ergonomics Society of Australia. Professor Melissa Baysari is a professor of human factors and leads the Digital Health and Human Factors Research Group at the University of Sydney. Her research group applies human factors methods and approaches to evaluate and optimise health technologies to support healthcare work and improve patient safety. Melissa has many collaborations with health services and government, and her research has resulted in a number of significant changes being made to clinical information systems as well as hospital policy and work practices. Mel, firstly, can I say thank you so much for joining us today on this podcast. And you are extremely experienced and a very well-respected professional, and I'm really enthusiastic about chatting about the work that you've done. So can you tell us maybe a little bit about some of the projects that you've been working on and what your role has been?
Okay, thanks, Sharon. Thank you very much for the invitation as well to speak. I'm quite excited about doing a podcast, and I've been listening to the HFESA podcasts myself. So so I'm a professor of human factors at the University of Sydney. What that means is that I lead a research team as well as do some education. Most of my education is in digital health, so not much on the human factors, although I try and integrate human factors into that. And my research team, the Digital Health Human Factors Group, our research is focused on trying to improve healthcare work and improve patient safety via good design of technology. But I'll say up front, I'm not a designer. I don't actually consider myself a designer. And most of the projects I do involve me and my team going out and looking at how technology is currently being used in practice and what changes would be needed to the technology or to the processes surrounding the technology to support safe and efficient work. So digital health is really ramping up. Like, it is everywhere now. It's not really possible for a healthcare provider to work in healthcare without interacting with technologies. And so there are lots and lots of opportunities out there for us as a group who works in this space, because I have to admit, human factors is kind of left behind. So I learn every day. I'm surprised at how little human factors input has been incorporated into the design and implementation of these systems. And as someone who's come through transport, so I started in railway safety, I was surprised at how few human factors people there were in healthcare. And there has been, I think, a little bit of an increase in that, but overall, I would say we're very far behind the other domains in our application of human factors methods and approaches. So there's a lot of opportunity there. And I think people who know what human factors is and what human factors can bring are the people who approach me and my team and go, oh, we have this new technology. We don't really understand why people aren't using it in the way it was designed to be used. Can you come in and have a look? And so then we do kind of work system analysis things, follow people around, look at all the tasks they do, the tools they use, do interviews with the end users to try and understand why the technology is not being used the way the designers or the organisations think it should be used. And there are lots and lots of reasons why that is the case. Design is a really big one. So we have a lot of problems with design, I think, of our technologies. But then there are factors external to that as well. So just, healthcare is a very complex system, a lot going on, a lot for people to do. And the systems that we implement should really support that, but in many cases they don't. A whole range of different types of projects, different types of technologies, different end users, depending on what problems need to be solved. we go out there and try and help solve those problems.
So what are some of the technologies?
My work probably started most in medication management. So I was based in the pharmacy department of a hospital for a long time and worked with them on trying to improve medication safety with digital health. And so we now in New South Wales don't use paper anymore for our medication charts. So everything's electronic. So doctors prescribe electronically and nurses administer using the electronic system and pharmacists review electronically in a computerized way. So it's all nice, which should be all nice and a linked kind of medication management system. But yeah, there are some problems. Again, with design, again, with how these systems align with workflow. And most of these large scale systems, so our electronic medical records, our electronic medication systems are US systems. And so they're designed with US workflows and roles in mind. And what we do here is slightly different to that. And so they have to add bits on and make changes to the system, or sometimes the organisation goes, we're going to create this workaround because the system doesn't let us do what we'd like it to do. And so we will just add this bit on. Everyone should do this. Everyone should do that. And so then you just kind of make the systems work because, they're the best we've got. And so mainly my work has focused on electronic medical records and electronic medication management systems. But I'd say in the last 3 or 4 years, I've really tried to branch out to look at different types of technologies because we're seeing a lot more of different types of technologies now being used. So I think traditionally when people thought about digital health, they thought about EMRs, electronic medical records, but now we've got so many things being added on to our electronic medical records and a lot of different devices and things being used. And so I've been trying to look at these other types of technologies as well as the standard kind of EMRs. But that doesn't mean that our EMRs are set and forget systems. They're continuously changing and there's a lot more work we need to do in our EMRs with respect to usability and a lot of other things as well. So there's no shortage there of problems to tackle.
So there are lots of users in this system. What are some of the users, or who are some of the users?
Yeah, so we have our clinician users. So obviously our doctors, nurses, pharmacists, allied health professionals, and then we also have our support staff. But when it comes to electronic medical records, I would say the clinician users are our primary end users, and each of them uses the system in a very different way and have obviously very different tasks that they need to do. And so that kind of brings some challenges forward with respect to, which parts of an electronic medical record someone can see and access, for example. Do you need to be able to make changes to this page if you're not this type of healthcare professional? So then there are some permission kind of things that organisations try to set up when it comes to giving different clinical groups access to the EMR. And the other thing is, even within a particular group, people do different tasks, right? So even if you're a doctor, if you're a senior doctor, you're likely to do very different things in the EMR than if you're a junior doctor. So although they have the same permissions, they're going to be using the EMR in very different ways. They have different roles in the hospital and different tasks they need to do. And so in thinking about that, thinking about the design of these systems, we've got so many different end users then with very different needs. And so it's hard to have this one size fits all system, right, that everyone can use and it supports everyone's tasks. And so I guess it's about having systems that are customizable or adaptable, that you can control what you can see and what tabs would be useful to you, what pages you would use, that kind of thing. So in addition to kind of a basic version of things, we should be having systems, we should be designing systems that support different types of tasks and different types of users.
You've indicated that you don't do a lot of design work and your role is mainly evaluation. So who is doing the original design work and are these users involved in that design?
Yeah, that's a good question. So, I mean, these are huge vendors, US vendors, and I assume that they have clinician groups who are involved in the design of these systems. In me looking at the system, I think they probably should have had more. Yeah, they needed to have more end users involved in the design. I think definitely we're seeing an increase in I guess people are starting to appreciate, user-centered design. We should be designing these systems with the users and with the users' needs in mind. I think historically that hasn't been the case. Most of these systems were designed as billing systems. So they were designed to support billing in the US because that's quite a big part of their healthcare. We don't have that here. And so making the transition from a kind of administration billing system to a clinical system, that's a big jump. And there are different types of needs, obviously, for a clinical system than a billing type system. And so sometimes people who use these EMRs joke about it and say, oh, my billing system rather than my EMR, because it's kind of designed that way to support them charging, et cetera, but rather than to support clinical work as it's done. So in Australia, we definitely have seen a need. And so, for example, organisations like eHealth New South Wales now have a design group as part of that with human factors experts embedded in that because they appreciate just over the years how many end users are complaining about the systems and all the needs they've identified along the way. They appreciate the value of having some human factors integration. So we are seeing slowly the uptake of these kinds of skills, but there's a long way to go, I think.
Does some of the feedback from the changes or add-ons that you make to the system get back to the designers?
That's a good question. I think some of it does, but definitely at a local level, they do what they can. So because it's the health service who come to me, not the technology partner that come to me and say, can you help us with the design? So it'd be the health service going, oh, we're really struggling with this technology or whatever it is. So then I'll go and do the evaluation with the team and then feedback and go, okay, these are the changes that are needed. And then at a local level, they do what they can. And then they communicate with the technology partner and say, these are the changes we need in our system, that we've identified, our usability issues or safety issues in our system. So that's a very interesting area for me, is the safety of digital health as well. So although usability is important, what we have found is that because the design of these systems is not very good, that we are seeing new types of errors and new types of risks that the implementation of these systems is introducing. And so those kinds of things I think are very important to address because healthcare itself is already risky enough. We don't want to be creating these extra risks with poorly designed technologies. And so it's the health service who then goes to the vendor and says, look, this is a safety risk for us, change the design of this. And some of them I'd have to say are pretty simple things that should have been identified pretty early on. I can give an example. For example, on a chart, for a medicine, for the user to see that if a medicine is currently active, they have to scroll horizontally, which is extra work for the person to do. It would be much better if they can see from the front page, from the first page, whether a medicine is currently active on the patient's chart or has been ceased. And so if the user doesn't scroll, they miss that information. So they'll look at it and go, okay, they've already on a warfarin. I don't have to prescribe warfarin, but actually, that's ceased, but you didn't scroll, so you can't see that it ceased. And so then the patient misses out on warfarin. So those kinds of things, it's just a simple design. Let's move up front, whether the medicine is ceased or active, rather than having it something that the user has to do an extra step to see. So those kinds of small design things, I think it's a shame, with user testing and with proper user-centered design, I'm sure all of these issues would have been identified early on, but now we're seeing all these small types of things emerge and then these extra we're seeing these incidents occur because of poor design.
So these systems aren't designed and then rolled out with a small user group, adopted by various organisations, health organisations, and then they find the emergent risks as they go. Is that what's happening?
Yes, that's right. So in our hospitals, we have, as you know, a very disjointed healthcare system in Australia. And so our digital health is also very disjointed. We don't have a single system that everyone's using, for example, as their medical record. So different states have used different approaches. In New South Wales, our hospitals use different systems. Most of them use the same type of system, but different configurations of the system. In other states, they've gone with everyone's going to use the same system in all their hospitals. In other states, they're like, it's free. Everyone can just pick whichever EMR they want to pick, right? And then that's just in hospitals. Then we've got general practice. Every general practice can buy their own EMR, their own system, and do their own thing, right? So it's very disjointed. And as a consequence of that, the data also doesn't follow people, right? So if you're a patient here in Sydney and you go to Royal Prince Alfred Hospital here and then you go to Liverpool Hospital, people in Liverpool Hospital can't see what happened to you at Royal Prince Alfred Hospital. It's different EMR, different systems, right? So it's very, very disjointed. And so New South Wales Health has gone, okay, this is a huge problem. We're going to implement a single EMR that all our hospitals can use. And that means it doesn't matter where patients go, all their health records will follow them. And the plan is they've now selected a system, and the plan is they're going to replace our current EMR with a single digital patient record, they're calling it. And the next 7 years, all hospitals in New South Wales will have the same EMR. That's the plan. But again, if a patient then moves to a general practice, that general practitioner can't see what's happened to the patient in hospital because they're using a different system. And so it is a very disjointed, unfortunately. And so if we make design changes to one hospitals or one district system, they don't flow on to other hospitals and other districts until we have a single digital patient record or a single EMR that will be used across. Then if a design change is made, hopefully that design change will flow through to all hospitals and districts using that system.
Wow, I wasn't aware that hospital to hospital they couldn't see the data.
It's crazy. Yeah, I think it's crazy. And most consumers don't know that because they expect... most consumers expect the data to follow them. I would expect my data. Or didn't you know what happened to me? So it is absolutely crazy. And it's the same with nursing homes, right? So if you're discharged from hospital, you go into a residential aged care facility. Obviously, that residential aged care facility can't see what's happened to you in hospital. So it's relying on a lot of the discharge information to be transferred across. So, and it's at these transitions of care where most errors occur. Because information is lost. And so really we should be designing systems that work across all settings and follow the patient, a patient-centric type systems. I guess I don't know how familiar you are with the My Health record, Sharon, but the My Health record was meant to be a solution to this fragmented healthcare system. So this is a federal initiative, so it's come down from the Commonwealth government that everyone has this My Health record. And that's supposed to be, a source of truth for patients as they move across our healthcare system. And I'm interested to hear what people think of the My Health record from a design perspective if they go and download the My Health record app and try to play around with it, because there are a lot of usability issues with that system as well. And that was meant to be a part solution, I guess, to our fragmented healthcare system.
Okay, so you flagged a lot of problems with adoption and you've mentioned patient safety and emergent risks. We've mentioned only a couple of those. So what are some of the other problems that you've had with adoption?
Yeah, so I guess if people don't see a need or a value for the system, then you're likely to get poor uptake of the system. And so there are a few ways that I guess, research or data could help with that. So when I was involved in some of the very early rollouts of electronic medication systems in New South Wales. And people were very, very reluctant to take these technologies up. They were like, why do we need to use an electronic system? We've got our paper chart we've been using for 20 years or whatever it is. It's a great chart. It works fine, and it was bringing them back to kind of, okay, so I'd ask questions like, how often do you think you as a healthcare professional make an error in your prescribing of a medicine? And people would say to me, error, I don't make any errors. Like, I never make an error. So very poor awareness of how well they're going. And that's not their fault. It's because they get very little feedback about how well they're going. So unless a patient's harmed or something like that, and it comes back to them, okay, you prescribed 10 times the dose or whatever it is, they just don't know that how many mistakes they're making on an everyday kind of basis. At the same time, we were doing some audits at the hospital, some chart audits to try and work out how many errors patients were experiencing. And we were finding things like 5 to 6 on average, 5 to 6 errors per patient. So 5 to 6 prescription errors per patient. Someone's got to be making these errors. Who's making these errors? If the people are masking and saying, oh, I'm not making the errors. So very poor awareness. And because of that, then they're like, why do we need a safety intervention like an electronic system when there are no safety issues? Like, there are very few safety issues. So I think data and research can help with adoption, because if you're able to present, so I gave presentations at the grand rounds and said, actually, on average, people are experiencing 5 errors. So we really do need some kind of safety intervention here. And so that helped with people starting to go, oh, maybe we should be thinking about an electronic system, so that's my first piece of advice, is that you need to create, I guess, improve the visibility of a need for an intervention. So that's the first thing. And then the second thing is just the whole design and workflow fit and stuff. It's a lot of work entering data into electronic systems. It takes longer than paper-based processes. If people think putting a system in is going to make them more efficient, I think that's the wrong message we should be giving to our healthcare workers. This system's going to reduce your time, documentation time, and make you more efficient. I think that's the wrong message. I think we should be pushing the safety benefits, because we know that moving from a paper system to an electronic system is much safer. We're seeing huge improvements. Over 50% of errors are reduced when you implement an electronic system. I think they're the types of messages we should be pushing, because things do take longer, and we have an aging workforce. Typing something in to a system, a lot of fields, it's a lot of work. Why would people do that if they don't see a safety benefit? The other thing is, our systems are so poorly designed that there's a lot of information that goes in that is never, ever used again, right? So people are putting stuff in, are required, all these mandatory fields they must complete, and then that information just sits there. It doesn't really get used by any other teams, doesn't really inform care. And so another big problem with our systems is that we need to take out the data entry fields that go nowhere and make the data entry meaningful for the end users, so that then they don't mind doing it, because they can see, okay, this information will be used here and here, so it's okay. So I'll give you a classic example of this. So for antibiotics, when you prescribe an antibiotic, you're supposed to put in the system the reason why you're prescribing the antibiotic, because we have so much overuse of antibiotics, right, that we want to know why people are using a particular antibiotic. So we ran a study where we looked at all the reasons an antibiotic was being used. So we pulled for over 1,000 antibiotics, the reasons people were writing for that antibiotic. And we found that over a third of them were gibberish. So people were writing things like, my senior doctor told me, in the reason for why they were prescribing the antibiotic, or they would just put like a string of text with the keyboard, from the keyboard, or they would just write something like ICU, intensive care unit, which isn't a reason for giving an antibiotic. And so when we interviewed the doctors about like, what's going on? Like, why are you not putting in the actual reason for your antibiotic in there? They would be like, who's checking that anyway? Like, that information goes nowhere. It's just a mandatory field we have to get past in order to prescribe the antibiotic. So they saw no value in taking the time to go, okay, this is the reason for my antibiotic. And as a result, it was like workaround. Basically, people were just working around the system to get the antibiotic to the patient. The problem with that is that those reasons for antibiotic don't stop there, right? So they follow the patient. They go on to the discharge summary. So if the patient gets all their medicines, they'd have all the medicines, and then it'll have the reason why you were prescribed that medicine. So then they'd have reason, and it could be like the senior doctor told me right next to the thing. So that was and then the hospital also used that to print their labels for their boxes. When they gave the patients their medicines to go home, they would print the reason from the EMR to go on the box. So then the reason on the box would be complete gibberish as well. But these reasons, like these flow-on effects, were not visible to the users of the system, right? So they had no idea. They thought that no one ever checked it. They said things like, no one ever pulled me up on putting something in the box which didn't make sense. And so that just tells us, that it's that kind of feedback thing. So you put an electronic system in, there's so much junk that people have to put in there, and people don't know where it's going or if it's ever being used. And if there's no visibility of the consequences of inaccurate data entry into these systems, and people are just going to keep using them in the way that's the most efficient for them to get the job done.
So this is all usability, isn't it? We've just discovered that they don't know what it's used for, and there is no feedback. So how have you been able to improve any of that, or have you?
Yeah, so I sometimes do usability testing, a standard kind of usability testing approach. But I have to say most of the work I do isn't just in practice, is in talking to people and looking at how, like, not usability in the sense of user testing where they're actually sitting there in a simulation using the system, but you could look at how the system is actually used in practice. And that's very useful for us, especially for identifying these workarounds. Because workarounds, usually you have to observe in the real context how people are using the system and how they're not using the system when they should be using the system. So I have used usability testing for some smaller kind of design projects, which I've done. And in that case, we create a mock-up of some element of the digital solution and then get users, create patient scenarios, usually involving prescribing or whatever it is, whoever the end users are, and then get the users to walk through it and, measure the standard things you would in usability testing. So satisfaction, efficiency, as well as effectiveness. So errors as they're progressing through the scenarios. I find those kinds of things really useful for the more earlier design kind of stuff. And also if we've decided we're going to redesign something, then we can create a mock-up of that and run users through some usability testing of that. But to complement those kinds of methods, I think the real life observational work is really, really important, because it doesn't matter how much usability testing you do in a lab. When you put the system out there, it's going to be used in a very different way. Lots of interruptions. Things are so fast-paced. I mean, every time I go out to observe in healthcare, I'm very, very shocked at how fast-paced things move. I've tried to even do time and motion studies, where you time users, how long each task takes. And it's so hard to keep up because there's so much task switching. And like healthcare providers are interrupted every few minutes, and then have to switch to a new task. So it's really hard, you can't see that in usability testing. You can only see that when go out there in practice and look at how work is actually done.
Yes. So how is work done?
Yeah, there's no standard. People value efficiency and will do everything they can to be efficient. I'm sure you're familiar with the efficiency thoroughness trade-off, which is this, how thorough do you have to be? How low can you get in thoroughness to be efficient, but you don't want to be creating safety issues? And so I think it's this constant thing, I want to be as fast as I can to get my job done. And it's because people are so overworked. They've just got too much to do. And so they try and find the most efficient way to do things. And this is a problem because it leads to workarounds and people using working around the technology because the technology is perceived to slow them down. I guess a very classic example of that is in nursing. So there's been quite a lot of work looking at nursing workarounds and how nurses, who really are one of our main users of technologies in hospitals, have figured out ways to work around the technology because the technology is really slowing them down. And so a classic example of that would be something like, most of our computers are on wheels in hospital, right? So you're supposed to wheel them around and they're supposed to follow you as you're doing your work. And for a nurse who's doing an administration round where they have to administer the medicines to patients, they're supposed to be pushing the trolley along to each patient bedside. Before we had computers, if you think about it, most patients had their chart at the end of the bed, right? So the nurse would take the chart, open the chart, go, okay, Mr. Lee, we're giving you your whatever today. Check the ID band, check the allergies, check the chart, make sure all the medicines they've got in their hand are the ones on the chart, and then administer the medicine and then sign it off on the chart. So when the designers of technology thought, okay, we're now going to just pick this whole thing up and put it onto the computer, we'll see the same thing happening, right? The nurse will push the computer to the bedside, we'll open the patient's chart, we'll check all the details and things, and then administer the medicine and then sign it off on the chart. But in reality, that's not really how it works. So what happens is the nurse finds the workstation and wherever it's available, whether that's a computer on wheels or a stationary thing, checks all the medicines, makes sure they're all okay, and then carries the medicines to the patient bedside without the computer, because then they have to push the computer in. The computer's very slow, very clunky. Depending on the size of the room, is it an infectious control room where they, getting a computer in and out? It's very challenging as well. And so what they'll do is they'll go, okay, I'm about to go into room, be over there with the 4 patients. I'll just do, there you go, 4, just tick all the medicines off that they've given them and then walk to the room and give them to the patients. So obviously that's a bit of a problem. Number one, because there's no check at the point of administration. Is this the right medicine for this patient? The chart isn't actually at the bedside. The chart's out in the hallway. So there are a few risks associated with that. And then the other thing is, say the nurse goes in and then the patient on the 4th bed is not there. They're in the shower or they're upstairs getting an X-ray. They've just marked off the medicine as given, but the patient's not there, so the medicine actually hasn't been given. And you can't undo things like that in an EMR. So it's been marked as given, and the patient didn't take the medicine at that time. So we see a lot of discrepancies between the time a medicine is given as documented in the EMR and the actual time a medicine is given. There's actually a big discrepancy between that most of the time because the signing doesn't occur simultaneously with the giving of the medicine. So that's a really classic example, which is used a lot of a workaround. And the reason why the nurse is working around is because that's the most efficient way for her or him to do it, for her to do it all in one go and walk into the room and give all the medicines in one go. That's the most efficient way for them to do it.
So how have you optimised that, or can you optimise that? What are your thoughts?
Yeah, so I guess it's making people aware of the risk of doing that, but then just making some changes to, so like one of the biggest complaints is the slow loading time on the EMR, right? Because it takes a long time to move between patients. The EMR is really slow. So that's why they just do it all in one go and then go and do it. So if we had faster systems, that might encourage people to take the computer to the bedside. The other interesting thing is that just the placement of computers. So we did some work looking at like how many computers people have on wards, where they put them. And this can really dictate where work is done. So if you have, for example, a computer at the bedside all the time attached to the patient, like this is this patient's computer, what you find is much more work gets done at the patient bedside because the computer's there than if you didn't have that. So more work gets done in the hallway then, because that's where the computers are, in the hallway. So placement of computers is also really important because it really dictates where people will do work and also make decisions. And, you know, having something next to the patient, I think, is really great because you might get more patient involvement and engagement in some of the decisions if the clinical staff always congregate there to make their decisions and the patient's right there, right? So that's really useful. And so I think designers of hospitals have to be mindful of that, where you put your computers, because as we're shifting to more and more, you know, computerized work, the work's going to be where the computers are, really.
So these are huge challenges. I was going to ask you what your greatest challenge was, but I don't think there's one that's greater than another. Maybe I should ask, what are some of the other challenges? Because these are huge.
Yeah, they're all really, really big challenges. Everyone wants to do really good work. What kind of irritates me is thinking that it's a human issue when I've never really come across in any project where it's a human issue. It's always a system issue. And so people want to do work. Everyone's a healthcare provider because they want to help patients. And so we should be helping them help patients by designing good systems and designing good work systems, not just EMRs, but like work systems as a whole. And so I think we have some way in healthcare to shift people's thinking in that direction, because people often think that, I think of things that let's retrain. It's a training issue. We need to retrain people, but that's not, I think that's a really, really bad attitude. I think we should be designing better systems so that we don't need to retrain, because people will just do the right thing naturally, right? Because the system's encouraging the right, whatever it is. And we're seeing some of that with nudge. So I don't know if you're familiar with this, Sharon, this nudge principles where you can nudge people to do the right thing. So instead of designing systems that kind of give everyone all alternatives, let's design systems that make it really easy to do the right thing and really hard to do the wrong thing. So I can provide an example of that. So, for example, let's take generic medicines, right? So we want people to prescribe generically. We don't want people to prescribe brand medicines. We want people to just prescribe generically. This would save a lot of money. There's no need for us to use particular brands. Let's use generic. And so there was a study which was really interesting. What they did was, when someone went in to order a medicine in the system, it doesn't matter what they typed, it would always revert to the generic, right? So even if they typed in the brand name, it would come up underneath, this is it, this is the order, and the order would be generic. And if the prescriber really, really wanted to prescribe with the brand name, they could click a box and said prescribe by brand, but it was one extra click. So it was more work to prescribe by brand. And so what they found is that before they introduced this small change to the design, it was something like 40% of medicines were prescribed generically. After they just changed the defaults, they would always prescribe generically unless they clicked one button. They ended up with 95% of drugs prescribed generically. So it's just a very small change to design, but it's nudging people to do the right thing and making it a little bit harder, not hard at all, but a little bit harder to do the brand name thing. And so that resulted in a huge change in behavior. So we can be smart in the way that we design our systems to nudge people to do the right things. And a lot of my research is focused on decision support, so how we can support people to make the right decisions using technology. And unfortunately, most people immediately revert to we should alert the end user to something. And so we have a huge problem in healthcare with alert fatigue. So let's just add another alert for this and add another alert for that. Oh, we've noticed that, this medicine is often prescribed at too high a dose. Okay, let's chuck an alert in then to warn the end user that they should, not prescribe at this high dose. And so people just immediately turn to alerts as the most effective way to change decision making. And that's a huge problem because it's not, we know that's not going to be the most effective way. And especially because we have so many alerts in the system already. And so just adding another one in there is just going to add to the alert fatigue. It's getting lost in this sea of alerts. So if we try and adopt nudge principles, I think that's what we need to do now. That if someone said to me, what would be your solution to our poor design of EMRs, I would say we need to be smarter in the way we nudge people to do the right things. So instead of warning them after the fact that they could have, this is potentially dangerous for a patient, let's just direct them to choose the right thing in the first place. Then an alert won't be needed, post-selection of whatever it is. And there are lots and lots of ways to do that. I think one of the easiest way, which we don't really utilize much, is just with drop-down lists, in systems. So most people just choose the top item on a drop-down, especially if you've got a really long drop-down with like every single medicine dose possible, with every single, people just go for the top one. And then afterwards they just figure out. So if it's the wrong, some element of the order is wrong, they'll just fudge it and, figure out a way to make it work. So what if we had really smart systems? And so you were prescribing, say, a dose of something for a patient, and the system was so smart that it knew for this patient at this age, considering their renal function and all this kind of stuff, I'm looking at all the complete patient profile. I know that the system knows the most appropriate dose for this patient is 500 milligrams. Wouldn't it be great if the system put 500 at the top of that drop down and made it clear to the end user that this was the most appropriate choice for this patient, considering all the patient factors and stuff? That would be the coolest thing ever, because everyone would just pick the 500, right? And then we'd end up with people getting the right doses. Our systems can't do that. We're way behind, but that would be really cool. I think that would be a really cool type of decision support. And all the other options which are inappropriate for that patient are not visible to end users. So we wouldn't get people making the wrong choices because it's just not possible to make that choice. We don't do that. What we do is we give an alert after the person's chosen the dose and say, this is the wrong dose. It just adds to the alert burden.
I'm wondering whether the reason for choosing a particular medication, which we talked about earlier, was to circumvent some of the problems that arise with the amount of drug dosage that's given. For instance, certain circumstances might dictate a higher amount of the drug.
Yep.
Are those two fields correlated?
No, so we don't have systems that are smart enough to know all these things. But what you're suggesting is correct. Like it should be, for this use, this dose is appropriate. For this, if you're using it for this dose is appropriate. So we're seeing, everyone talks about AI, and AI in healthcare is just, skyrocketing. I think we need to get some of that AI into these EMRs, so can't they tell us, and I mean, there are lots and lots of, obviously a lot of other challenges we'd have to deal with, but our systems are really, I always call them really dumb. Our decision support systems are really dumb. They don't take into account anything. And they've just got very basic algorithms in there. The most common one, which I could talk about for 5 hours, because I do a lot of my research on drug interactions. So this is like when a drug interacts with another drug. That's our most common type of alert that we have in our EMRs, and that's in GP systems and in hospital systems. That if a user comes in to prescribe a drug and it could potentially interact with another drug on the patient's chart, then an alert fires that says this drug could potentially interact with this drug, right? But our systems are so dumb that it's just drug. That's all they take into account. So it doesn't matter if you've given a very small dose of one and a very small dose of the other, too small a dose for them to interact. It doesn't matter. It doesn't matter if you've ordered one as a topical ointment and the other one as a pill, and so they can't actually interact. It doesn't matter. It's just drug. If these two drugs are prescribed, the alert will fire. And so that's why we have so many alerts, because if they took into account all these other factors, so, the routes, the doses, the patient factors, this is a very young patient, they can tolerate these two drugs together. Let's not fire the alert in this case. Then we would get very low numbers of alerts, because our alerts would be smarter and more clinically relevant for the particular situation at that time. But our alerts currently don't do that. And so that is why we have hundreds of alerts, and why we have alert fatigue, and why we're also seeing, unfortunately, patient harms resulting from people ignoring alerts. So, an alert popped up, it wasn't noticed because there were so many other alerts. And so then a patient gets a double dose or whatever it is, and the patient's harmed from that. And so people go, that's really careless on the end user's part because they should have seen the alert. And I'm like, no, that's really careless on the designer's part, because that prescriber received 16 alerts. What are they going to do? Read those 16 alerts at the point in time where they're really busy, and, that alert looks like all the other alerts, which don't mean anything for, and are not relevant to the patient. So we're getting there, but I think people still see it as a kind of end user thing as opposed to a design thing, a design challenge, which we are facing.
Yes, you've mentioned so many things there, and we could talk for hours about this. Is there any other way to improve alert fatigue?
Yeah, so we're tackling it from different types, trying multiple strategies. So eHealth New South Wales here, which is our state government, has recently developed a guideline on clinical decision support, and it's kind of a flow diagram. And you go through each of the kind of questions, and then it tells you at the end do you need decision support, number one, and then yes, if you do need decision support, what types of decision support should you consider before you land on an alert, right? Because the alert should be your last resort type thing. And actually, we're trialling the guideline at our conference in a few weeks, where we're getting end users to come in and come with their cases of decision support where they want to know whether they need an alert or not, and try the guideline to help kind of inform their decisions about decision support to include in their EMRs. So if people are around, I think we still have a few slots available. This is a breakfast workshop on the 5th of July at Sydney University. They can reach out to me or to HFESA if they have questions about it, because HFESA is also a sponsor of our large conference, which is happening in a couple of weeks in Sydney. But yeah, so that's one way, is that we're trying to give people guidance on how they can make decisions about their decision support. The other way is to provide evidence. And this one's obviously interesting for me as a researcher, is to provide evidence on whether decision support is effective or not to help inform those decisions about decision support. So the drug-drug interaction one's a good example because this is a project which is very close to my heart and I've been working on for nearly, I think, over 5 years now. But in this project, what we're doing is we're running a control trial to determine whether putting these alerts in actually makes a difference to patients. So I mentioned that they're the most common type of alerts that people receive. And so as a clinician, you would encounter many drug-drug interaction alerts every day as part of your prescribing. And so for this study, what we're doing, so we had a series of hospitals and some of them act as control hospitals and some of them act as intervention hospitals. So our control hospitals did not turn on the drug-drug interaction alerts and our intervention hospitals turned on the drug-drug interaction alerts. And we're comparing the impact of this decision on patients. So whether patients experience fewer drug-drug interactions in the sites that have the alerts and whether patients are also harmed, because I guess the whole point of this is that we're trying to prevent patients from being harmed from medicines. So do we see fewer patient harms associated with those drug-drug interactions in the intervention sites? So we're rounding up the trial. The trial will be finished in the next few months and we'll have an answer to our question, which is, do drug-drug interaction alerts prevent drug-drug interactions? And I don't, bit of a spoiler alert, I won't, but it's leaning towards no. The answer to that question will be no. So implementation of drug-drug interaction alerts do not prevent drug-drug interactions. And so armed with that evidence then, say we've got the whole trial completed, all the stats done, everything. Here's our final result. What will people do? Will people say, okay, we're going to turn off our drug-drug interaction alerts in our electronic medical records, or will people just continue status quo, just continue on and maintain their drug-drug interaction alerts in their systems? That's a really difficult question, and it's a dilemma I think people will have to face. I mean, it's a safety. It's viewed as a safety intervention, so it's kind of like going, okay, I'm going to turn off the mirrors on my car on the side because I just found out that they actually make no difference to the blind spot accidents. Right. So if you knew that there was a safety intervention, which everyone thought was a safety intervention, and the evidence shows that it actually doesn't improve safety, what would you do? Would you turn that safety feature off, or would you just maintain it in case it comes in handy some of the time, even though it probably won't come in handy? So it's a really difficult question, and I don't want to force people to. I'm not the implementer. I'm just providing the evidence, and then people can take that evidence and make a decision based on that. What I will say is that I think about those little lights that come on my mirror on my car, and I actually don't think that there's any negative consequences of having that going, even if it doesn't make a difference, as long as it doesn't lead to people relying on it and it's not actually working, right? So automation bias or whatever it is. But the alerts is something different because the alerts take a lot of time. They cost a lot of money. A lot of clinicians are spending time clicking through, reading the alerts, or, it's a high cost intervention. It leads people to become very frustrated at the EMR So when I ask people, what do you think of your system? People immediately say, oh, the alerts, the number of alerts I get, there's so many alerts. And so it's leading to negative views of the EMR in general, even though it's the alerts themselves which are causing problems. And the other thing is the safety risk. So by having so many alerts, people are missing some of the important alerts in there. So if they're not actually effective, shouldn't we take them out so that they can notice the effective ones that are left? So there is a negative consequence actually of keeping the alerts in there, even though, it's a proposed safety feature. So yeah, they're really difficult decisions, but that's been my two-pronged approach to how we can get rid of alert fatigue, Sharon, which you asked me, which is one is the evidence. So can we provide evidence to help people make decisions about which alerts to put in and not to put in? And the second is, can we give people guidance, make them aware of the negative consequences of having too many alerts in a system, give them guidance on whether this decision support is the right decision support for that problem that they're trying to target with an alert.
Wow, you've given me so much to think about. I guess I was thinking that AI may be extremely useful in this, and then the question is how serious is an alert? And
that's right. And I also have this question about how much can people tolerate? As a user, how many alerts can you see before you start to just ignore the alerts? Like, we don't have that threshold of like what's an okay number. I did try to run a study on that. Like, I wanted to know that because I thought maybe I could say to hospitals or whoever, you can only have this many alerts, and then once you hit that point, forget it. So make a decision about what alerts you want to put in that before you hit that level. And so what I did was I recruited medical students, and I created these scenarios, and I used the training version of one of the hospital EMRs, and I created these scenarios where they got like varying levels of alerts, and then I looked at how using screen capture, looked at like how long they were spending on each alert screen, and when they started to stop, because I was interested in when they stopped reading, right, when they just started to click past without reading. But I couldn't answer the question because I found there was too much variability. Like, people have very different tolerances for how many alerts they can handle, I think, before they start to ignore the alerts. And I think that the thing is, it's individuals, but also it's context. So depending on what else you're doing, it might vary. So how many alerts you can handle might vary depending on what it is you're doing, and also your previous experience of alerts. I mean, most of us would be familiar with alerts through like Word or whatever. It comes up. Sometimes I click without even reading what the warning says. And so all of us have some experience of alerts, but in EMRs, I do wonder about like people who have never, ever seen an alert in an EMR before have probably a very different view of alerts than someone who's been working in an EMR for 10 years and seen, hundreds and thousands of alerts that don't mean anything to them. So there's a lot of individual variability, I think.
Mel, your work is fabulous, and I'm looking forward to chatting with you again about some of the other projects that you've been working on or are working on at the moment, and particularly to talk more about this alert fatigue. Thank you so much for your time today.
It's been my pleasure, Sharon. Thanks very much for having me.
If you're interested in the conference that Professor Baysari has mentioned, the Context Sensitive Health Informatics Conference is to be held in Sydney over 2 days on the 5th and 6th of July at the University of Sydney. This is the pre-conference to MedInfo 2023, which is the World Congress on Medical and Health Informatics. If you're interested in attendance, search CSHI 2023 Sydney. Thanks for joining us at the Human Factors and Ergonomics Hub, brought to you by the Human Factors and Ergonomics Society of Australia, where human-centred design really matters. If you like this podcast, make us your favourite in your podcast app. We look forward to chatting with you next time.